Or you could
Yes, I can see those.
let yourself in if you'd like.
Next, no, here, coffee seat. Coffee seat.
And here, you
Health Fund is going to focus on is breast health screening for uninsured and underinsured women. And I'm going to focus on the community need, the program model, and the impact. I want to just share, I have 20 years of experience working with programs like this in other counties, in other states. And I've seen the effectiveness and the fact that these programs save lives. I also have a personal connection. I have several family members who are breast cancer survivors. And it's given me the opportunity to have peace of mind that our community has access to services and diagnostic services like this. Oh, thank you. Yeah. All right. So what the ask is Treasure Coast is requesting $300,000 to provide screening and diagnostic mammograms, ultrasounds, and biopsies for the Women's Health Fund. We seek to serve 1,000 indigent women in Indian River County, and we will be providing screening mammograms, diagnostic mammograms, ultrasounds, and biopsies. Our goal is to remove financial barriers to early detection and save lives. So what is the need? So women face a 13% lifetime risk of breast cancer, according to the American Cancer Society. Rates are increasing, especially in women under 50. Mammograms significantly reduce mortality. 14% lower risk for women between 50 and 59, and 33% lower risk for women ages 60 to 69. Early detection provides significant medical, emotional, and economic benefits to these women. And it is a less expensive way of managing versus advanced disease. So let's talk about Indian River County. So cancer is in the top 3 causes of death in Indian River County. And that can also be attributed to an older population, which is at greater risk. Women are at greater risk for breast cancer. Basically what we see is there's overall higher cancer rates in Indian River County than the Florida average. And breast cancer, there's higher diagnosis than the state and significantly higher death rates. There's a clear gap in the need and access. Approximately 200 women were diagnosed with breast cancer in Indian River County in the past year. So the Women's Health Fund. What I have to say is this is a program that's been in existence for quite some time. And really what we do is we have our providers speak with each female patient and screen them for breast cancer risk. When a woman is overdue or has not had the necessary screenings, the provider puts in a referral to assist and ensure that the woman gets these screenings. Some of our patients do not have insurance and they don't have an easy route to get this mammogram. And so that's where the Women's Health Fund comes into play. There are eligibility requirements. They use our Health Navigator through the process. Sorry.
No, it's not you, it's somebody
Okay.
on Zoom. Okay.
They work through the process of eligibility and appointments are scheduled. We currently use Vero Radiology as our provider, and we have negotiated very low rates for those services. Results come back to our providers, and our providers work with our patients, and our care coordinators support the patient through the entire process. And that's the important part. They help through a warm handoff and continue the communication and work with our patients. So why the Women's Health Fund? So we have over 16,000 uninsured women in Indian River County. 6,000 of them live below the federal poverty line. Oops, I'm sorry, I'm not forwarding. I apologize. Wait, oh, go back, sorry. Okay. And some of the challenges that these women experience are language differences, limited phone and internet access, and difficulty navigating the healthcare system. And I think we can all identify how hard it is for ourselves to navigate, but our patients struggle. And these funds will provide financial help and navigation for our patients. The women are supported through the process. And again, I have to reiterate, this saves lives. So the numbers. So in 2025, our Women's Health Fund provided care to 799 unique patients with 1,743 encounters. This was up significantly from the previous year, which was around 350. We anticipate seeing about 1,000 unique individuals and 2,550 encounters. And that's due to more folks, more women losing their insurance, whether it's through the ACA, or other reasons, they don't have insurance. And when you don't have insurance, you don't have access to preventative care. There's also new guidelines that are required for women for screening. So if women have dense breast tissue, they not only have to have a mammogram, but they also have to have an ultrasound. And that is important. And the more encounters we're doing, the more accurate diagnoses and the more women that are given a diagnosis, if that's the case.
Can
So,
I ask a question?
Sure.
Go back to the last slide, please. So 1,000 unique individuals, 2,500 encounters, basically 2 encounters per person, is that, or?
Yes, it does go further. So if there's something identified, then we move into the biopsy stage.
Okay,
We do
so
it.
some women have
yeah.
1, some might have 3 encounters.
Correct.
Okay.
Yeah, it goes from screening to diagnostic to potentially a biopsy. Yeah. So the impact. So first of all, as I've started my presentation, mammograms save lives. They can help to detect breast cancer early when the treatment there's more treatment options and before it spreads and becomes invasive. In terms of invasive breast cancer, early stage is a 99% survival rate. That's amazing. Invasive cancer survival rate 5 years is 90%, in 10 years it's 83%. What this fund does is it ensures early diagnosis, better outcomes, and peace of mind and extended life. And what I would like to say, I would like to share a quote from Don McPherson. True prevention is not waiting for bad things to happen, it's preventing things from happening in the first place. And that's what this Women's Health Fund does.
Thank you.
Thank you.
Any clarifying questions? Micah?
In a synopsis that have been prepared by staff, clearly everything you spoke to is primarily breast cancer. But it also noted cervical cancer. Is that if somebody presents and there's something there, then you will go in that direction?
Yes, yeah, most of the women using the program are for mammogram purposes, but yes, there are some patients that have to be referred out for cervical as well.
Okay.
Thank you for asking.
I had a question related to where is the funding being used for specifically for the mammograms, for biopsies, combination?
It pays for all of those things.
All of those things.
Yes.
So my understanding, breast cancer is an epidemic.
Yes.
Children and a wife with breast cancer, so I know you're connected.
Yeah.
But I'm understanding that the success rate with mammograms is probably 90%, but not 100%. So what is your plans with respect to MRI or other adjunctive testing of those people, and how does that cost get paid? Noting that MRIs are out like 3 weeks now in different counties.
Correct, yes, no. So when we move further down the path, we also look to have patients use the hospital, the FAP, the Financial Assistance Program. Because at some point, we go through the entire process, but the number of women that would need an MRI or such is so much lower. But yeah, we look at all options. To try to help.
And those who need surgical treatment, mastectomy or otherwise, where is that funded
That-
for this?
No, once we get to the diagnosis, then we work with them. We get them connected to assistance programs to help pay for the cost, yes.
Okay, great,
Yeah.
thank you.
No problem.
Karen?
The cost of encounter, I am sure it differs depending on which type of,
Correct.
but average.
That's a good question. I don't know that I have that information.
Right now, it's about 100, the average is about $178.
Thank you.
Okay,
That's
thank
the
you.
estimate, depending what was done.
Okay.
Thank you.
Yeah, Paul.
If I'm understanding, first of all, you've had funding which you no longer have access to, is that
No,
development, or are you just expanding the program?
we're expanding the program. So what happens with programs like this, and it's not unique to Treasure Coast, is there's never enough funding. We often have to stop services at some point during the year. And last year, we had such a growth up to 799 patients. It just exponentially, so we sought additional funding to ensure that no woman falls through the cracks.
Okay, so $799, you're expecting with the funding that you can go to 1,000 patients. And to summarize, you're serving as a PCP in order to help the women initiate the diagnostic process and then facilitate treatment if necessary.
Correct,
And you have partners on the treatment side
correct.
as well as, I guess, the diagnostic side. On the encounters, are these part the a wellness check includes this? In other words, if a woman comes in for a wellness check, or is this a separate and distinct visit? And part of the thought that I had just in terms of making sure that we're managing the dollars and the time is, are there two appointments that can be combined in order to facilitate the diagnostic commencement?
Okay, so the first question is for when women come into our facility as a federally qualified health center, part of our process is to screen to ensure that they're meeting all of the preventative requirements. In terms of the question about when they have a visit versus screening versus diagnostic, the screening has to be done first. It has to be read by a radiologist and it has to be determined that they need to move on to the diagnostic. And there's an order that has to be put in by the provider to do that. So that can't happen on the same visit. Although the ultrasound and the mammogram, the screening mammogram can happen on the same visit.
And Michael referred to a summary that we received, and it did say pap smears. How does that figure into the program? In other words, is it that part of the same screening routinely, or is it based upon an indicator?
So what would happen is a woman would have a normal pap smear in our office and it would come back abnormal. We have a gynecologist on staff. There's certain procedures that she can do, but once it goes beyond that, then they would be referred. So, but a lot of this does fall into the well woman visit that a lot of women have, but we also track it at every visit because not all of our patients come in for preventative visits. And so we want to make sure that we catch folks as early and quickly as possible.
And the only reason, just for the benefit of the taxpayers and community, that we're being as efficient with our
Yes,
billing and we have overlap where we can on the visits.
Absolutely.
Is the point of that.
yeah, no,
Thank you.
absolutely. Mhm.
Alan,
I just wanted to, I apologize for being a couple minutes late.
Okay.
If you get the bridge open,
I've heard that, yes. I am.
I wanted to ask you a question. Last year you did $799 in unique patients, and now we'll go to 1,000, which is about a 25% increase. But the budget overall that I've got here in front of me is 409, you want 300 from us, so. That seems like a disproportionate increase for the amount of new patients that we serve. Wonder if you speak to that.
Yeah, so what's happened, one of the things that's happened is because of the requirements for the ultrasound, many women have dense breasts and they have to have that. And so that's where the challenge has been. The initial process was that women would get a mammogram, but the cost has gone up exponentially because of the fact that many women have to have the ultrasound. And it's a requirement.
Oh,
So
so you haven't been able to do ultrasounds for many of these women in the past?
no, what happened for us is we had a limited amount of funding, so once we ran out of funding, we had to just
You guys
stop.
stop.
Correct.
Okay.
So, and what happened was previously we didn't have that ultrasound piece and now we do. And so we want to make sure that all women have access. We had to stop the program this year because we didn't have enough funding to continue.
When did you stop it?
We stopped it at the end of the year, at the end of 2025. And we do have a little bit of funding right now. And so we've been able to open it back up for a short period of time. Yeah.
Others
So that's
forces,
something we need to take a look at.
what's
Have we
that?
have we been funding this program previously? This isn't a new one.
No.
New to us.
Yeah.
So I want to remind trustees, this isn't your only opportunity to review this and to ask questions. I wonder if a lot of these questions are answered in the application. Dr. Mackey, I saw your hand, but we haven't had.
We have time.
We have time, but I just want to make sure that we're,
Yeah, I just wanted
Keep it
to
on.
address, this is Dr. Mackett speaking, I wanted to address trustee Jones's question. So in the past 2 weeks, I've seen 2 women. Younger women with dense breasts that fall into this new category who needed ultrasounds, and both of them required a diagnostic mammogram after that. So last year, there wasn't that requirement. So it's added additional studies and work.
Okay, thanks.
Heather, anything else?
No.
Thank you very much.
Thank you.
Well
Thank
done.
you.
Okay, Indigo Medical Society We Care Foundation, we have Danny Wynn with us. Good morning.
Good morning. I'm gonna have you guys, I'm old fashioned, I'm gonna have passed around.
Whatever works.
So papers. That's my paper. Yeah. Sorry.
No, I
Okay.
that's my type.
Oh, yes, I'm sorry. I like the paper old fashioned. Touch it, feel it, see it.
It's all good.
Yes. I just like to say good morning and thank you to everybody for even considering our LOI and looking over it and having us come here to present today. We in your pamphlets, I provided an overview of what our program is requesting. Together, this program is, we're going to improve access, improve outcomes, and reduce preventable disease burden on our on the uninsured and underserved here in Indian River County. The GI program is what we are requesting funds for. Currently, we are requesting $27,000 for our program. This program has one of the most critical access points for our patient population. Colon cancer is the number 2 most preventable cancer in out of all of the cancers. Our primary objective here is to increase access to diagnostic and specialty GI services, including the evaluation of chronic GI conditions and symptom-based referrals. We want to strengthen early detection of colorectal cancer and other serious gastrointestinal diseases, where timely intervention is essential for survival and long-term outcomes. We want to reduce and improve the emergency utilization by ensuring that patients are evaluated in an outpatient specialty setting rather than presenting at advanced stages of diseases in the hospital. And we want to improve the condition between our primary care providers and our specialty GI services, ensuring that patients don't fall through the gaps or the referral pathways. So the community impact. The impact of this program is very significant. We're seeing improvement already by having access to colonoscopies and diagnostic evaluation for our patients who previously had no valuable pathway to care. We are also identifying conditions early, supporting and reducing an advanced disease presentation. Our plan is to serve approximately 120 unique patients annually with 240 encounters per year. We are going to increase the rate of complicated preventative screenings among the uninsured population and identify these conditions early on as a treatable stage, particularly colorectal cancer. We are going to reduce the the emergency room department hospitalizations associated with advanced preventable GI conditions, and hopefully improve the overall health and outcomes and the quality for all of our participants. Currently, we are conducting monthly GI clinics where we have a volunteer gastroenterologist who is determining the need if the patient needs the diagnostic testing and provide any pre-procedure education and medications. Part of our grant, we're looking to help our patients have access to all the pre-medications that they would need before getting a upper or lower exam. A lot of times we have noticed that our patients aren't able to afford the medications to get a clean read is what the doctors are looking for. When you're going in and evaluating and looking at a patient, whether you're doing an upper or lower, you want to make sure that the area is clear. So that's one of the processes that we want to utilize, is to be able to open up the cabinet and hand those patients the necessary items that they would need so they would be able to get those clean screens. So our GI clinics are held on a Tuesday. That Friday, they're getting their colonoscopies. They don't have to wait a month, they don't have to wait 3 months, they're getting them within that time frame. The actual medication is a 1 day prep. There's no 3 day preps. They don't have to take time off of work except for that 1 day. We're trying to make it more accessible so that patients will be more willing to follow up. We're also looking into making Saturday clinics so patients wouldn't have to take any time off of work. A lot of times our patients have to decide whether or not they are going to put food on the table or get the screenings done. Our monthly colonoscopies right now, we have partnered with Live Oak Endoscopy, where they have graciously provided the procedure room for us. Our GI doctor has been allowed into their facility to provide those screenings. We also got sovereign immunity for some of the physicians there. In case we do get inundated with patients, we're able to get them seen. They've actually opened up Friday after all of their procedures are done for the day. And then we have the clinic space. Their nurses and their techs volunteer their time to come see us. We've also partnered with a Boston Medical Supplies, who helps provide the snares and things that are needed when we are actually doing the biopsies. Those things at this time, they're being donated to our services. But what's included into the encounters is if they decide, or if the patient needs more extensive biopsies, that we would be able to do that. Unfortunately, with one of our costs, we have pre and post medications that are needed for the patients. We don't want our patients awake during this procedure, and so they need to have this medication. And with that, it's part of a hard cost that the facility would need to take that cost. So we help reimburse an at-cost price for that medication. And that's where also part of the amount that you see, the $112 per encounter, that also is included into that. Our patient navigator coordinates all of this. It starts with the patient coming from the primary care physician's office, most of the time with a positive Cologuard screen, which they're getting through their primary care. It's great that they're doing the pre-screenings, but a lot of patients don't know where to go after that. So they come to us and then we're able to go further. Some of these patients, it's a positive screen and we go in and everything's great. Some of our patients have no symptoms. They have no symptoms of everything. And then we go in and we had a 49-year-old patient that came in, never had any issues, and we were able to remove a cancerous polyp due to our new program. The program leverages a network of committed volunteers and physicians that we want to deliver the high quality, no cost care for these patients. These patients do not get a charge for any of these services. We utilize, whether it's our fundraising or our grants, to help make sure that these patients are seen. Our data tracking, and we evaluate every patient. We track all of their where they're located, what their needs are, and it doesn't just stop there. If they need further testing, and then we partner with Cleveland Clinic, we get them part of the financial assistance program, and then they take it over from there. Cancer, again, like I said, colon cancer is a highly preventable death if caught early. And a lot of these patients need that screen. And we're hoping to be able, even if they have a family history, we have a patient that has a family history. He comes in once a year. He wasn't able to get it because he lost his insurance. And we were able to provide that screen, and he had a clear colon screen. I was given permission to share. His brother had passed away at a very young colon cancer, and he was very nervous about it. And we were able to give him that peace of mind. So we're hoping to help continue support this. We're hoping to increase our encounters and increase We Care. I think the main thing is to get our name out there and let people know that we're here. We've been working very hard with Whole Family Health. TCCH, I have a meeting tomorrow with Cleveland Clinic and Orlando Health to get those referrals over to us so we can get these patients the care that they need.
And that's the referral sources is Cleveland Clinic, Treasure Coast, Whole Families.
Yes, Whole Family and Orlando Health. We also do self-referrals. Sometimes we have patients that go into the United Against Poverty Center and they go and talk with the crisis center and they're homeless. They don't have a primary care physician. They're having symptoms now. I've developed a history and physical page that is easy for them to fill out. It's very streamlined. So I can sit down with those patients and identify their needs without getting into a primary care because of accessibility. Not that we don't like to do that on a norm, but if they need to come in and to sit down with a nurse, we can do that, try to get everything we can for them, and then the doctors can review it from there.
Question, Dr. Cooney?
Yes, Bill Cooney, so the process is the patient, the woman is saying, a doctor at GCCH or Whole Family Health or their own private practice, then they determine that they don't have the funds or that they need your help through WeCare.
Correct.
And the primary care doctor is providing the Cologuard and the other pre-diagnostic testing.
Yes.
And then you're paying for the prep, go lightly and all that fun stuff.
Yes. Yes.
Okay, and then after that, if it's positive. Colonoscopy, what's the next step that you refer them to, again, Cleveland Clinic?
Correct. We would then refer them to Cleveland Clinic. We also partner with Moffitt. Even though the great thing about WeCare is that they do need to be Indian River County residents, but the physicians don't need to be from Indian River County. We can also reach out to other facilities. Moffitt does great work with the underserved. And so they have a lot of charity programs as well. So wherever we need to get them, we can then get them to there.
And then are you doing upper and lower GIs before colonoscopy, or is that from the primary care doctor?
So the upper and lower is part of the colonoscopy part. So what the upper and lower, a lot of times we have patients that come in with acid reflux or GERD. They're having upset stomachs. We don't know what's causing it. So we need to do an upper and a lower. Those are done at the same time.
And that was my next question. You have someone who does endoscopy, GI endoscopy?
Yes.
Yeah.
Yes, our physician does both ends. Everything's, yes, essentially at both ends is everything is covered. A lot of times we originally go in and we're just going in for an upper. And then the doctor's like, you know what, we need to make sure we're covering it all. So we go upper and lower. It's all within one visit.
Sounds like you have all the bases covered.
Yeah.
Other questions? Michael?
Additionally, there's an anesthesiologist involved.
Yes.
I just didn't hear the word, so I mean, you've got those doctors lined up.
Yes, yes, we have the anesthesiologists as well. They're the ones that are providing the medications that we're reimbursing for.
Got it.
Yes, so the anesthesiologists are there as well.
Good.
The facility itself has everybody there. Like Live Oak is a full access. And we've been very lucky to be able to have found this little Easter egg to help us with this. And like I said, oh, yes. And like I said, sorry, the GI physicians there also, we got sovereign immunity for the entire complex. So everybody from the receptionist on is covered. And then all the physicians individually that wanted to help participate are also covered.
Yeah, I just wanted to highlight, your average cost per procedure is $112.
Yes, sir.
It's crazy.
I don't know how you did it, but keep it up.
Yes.
We have generous people out there, volunteers, our physicians. I don't know if you know, we have over 45 volunteers here in Indian River County that volunteer their time. We help it by reimbursing, again, the hard costs, depending if it's cataracts, because we also have an ophthalmology program, or Avastin injections, which is help preventing, other issues, eyesight. I mean, I see about half of us are wearing glasses here at this table. If we took those glasses off, we would be at a disadvantage. So, we're very grateful.
You guys
Very
are
grateful.
Great collaboration.
Very.
Appreciate
Danny,
it.
I just want to punctuate something you said. So you said it early and then add one other thing. This is a cancer that is preventable.
Correct.
If identified early, screened and, the polyps are dealt with. So this is preventable cancer. The other thing that I think just about everyone has seen, because it's been on the news all over the past 3 to 5 years, is that the average age of people with colon cancer, last month was Colon Cancer Awareness Month. This is by no means an older person's disease
No.
anymore. You have younger people, and all the researchers don't have answers to the why, but at this point, the reality is younger people are getting it. The screening age from the US Preventive Service Task Force was dropped to 45. Some people with family history are getting in their late twenties, thirties, so this is something that this can be a really big preventive investment for the district and save lives.
Yes.
Should the district decide?
Should the
on that?
district
It
decide.
should the district, yes, should the district decide, yes, absolutely. But yes, it's something that it's one of, again. The cancer, unfortunately, cancer affects everyone. But if we can screen early and remove a polyp early on. We had a huge event over at Live Oak where we invited the community just to get the word out on colon cancer and prevention.
One last question, who does your pathology from the biopsies?
We have, actually at Live Oak, their pathologies are done and the pathologies are done for free.
Right there, they have.
Yes, they have the ability to do the pathologies. The pathologies have been donated. There's an agreement that as long as we are doing the screening there, the pathologies is written into the agreement that they would do them for free for We Care.
That's nice. Mhm.
So we've tried to decrease the costs.
Thank you very much.
Of course, thank you.
Appreciate it.
Thank you.
Okay, next we have Senior Resource Association, Robin, with 2 programs to share. Welcome.
Madam Chair, do I need to leave the room?
You don't need to leave the room, we're just discussing.
Okay.
Perfect, we're not actually making a decision or taking. a
Okay,
vote, and
thank
that's
you.
why Dr. Mackey, or not leave the room, we're the first presentation.
I know, I saw that, I thought he snuck his way.
The clip on it. Just let us know when you want me to put it up.
Okay, I'd go ahead and put
Go
it.
ahead, okay.
Well, thank you and good morning. Also, co-presenting with me is Rosalind Diaz, our Director of Senior Services.
Do you want her to come to the table?
Yes, if that's okay.
Absolutely.
Yeah, we just
She can
scoot on
Pull
there.
that chair up behind
Yeah, just pull
you,
it.
yeah.
And also,
Oh, morning.
and also Gabe Pedrero, our CFO, is with us and he'll be available to answer any questions as well.
Great.
So
Don't sit on somebody's lap.
So first, I'd like to thank the trustees for reconsidering these 2 programs that are really vital in our community. And I'm really pleased and delighted that you've invited us to come and speak and talk a little bit about them. So the first program that we'd like to talk about is our emergency alert response systems. So this is a 24/7 electronic monitoring system for vulnerable seniors who can't afford but need the system. The devices, when pressed, prompt voice contact from trained professionals who act quickly, and then they are able to receive care on site by responding EMTs, or they can be provided transport to an emergency facility to receive a higher level of care if needed. So what are the devices? There are the wearable devices, which I'm sure you're familiar with. They wear them around your neck. There's also a watch that you can get for that as well. There's a stationary alert boxes, and then there's also a lock box that can be on your door just in the event that an EMT or emergency personnel need to access your house in an emergency. What is the eligibility of our clients? They must be residents of Indian River County, age 60 or more, or 18 to 59 and designated as disabled. Their gross annual household income should be below 250% of federal poverty guidelines. And this really addresses goal 2 for the district to expand access to care for uninsured and underinsured individuals, including the ALICE population. The ALICE survival budget we know is $37,272. In a recent survey that we had, a client satisfaction survey, 64% of our clients reported having income below $30,700, and another 11% between $30,701 and $38,700, which is far below the ALICE budget for seniors. Clients must also be at risk for falls and known to have safety concerns relative to their home environment. So I thought it would be important to point out the number of clients that you all have funded over the years. In 24-25, we had 370 clients unduplicated that were funded by the district. And we know that with the reduction in funding this year, we had to reduce that number drastically to 233 clients as of March 31st of this year. And next year, Rosalind's gonna talk a little bit about why we can increase the number of clients that we're projecting to serve next year up to 467. So this will virtually, I won't say wipe out the wait list, but it'll accomplish a lot in terms of providing service for the 288 people that are currently on the wait list. And by the way, we do have 30 additional people who are served by this program through the community care for the elderly funding through the state. So it's not a lot, but we use every dollar that we get from the state for this. So how is this preventive? How are we serving these individuals and what is the impact on our community? So in the last fiscal year, there were 17 calls that were made or 17 button pushes. Which may not seem like a whole lot, but for the 233 individuals that we're serving, or 300, for these people, this service was critical to maintaining their health. Of those 17 calls, 12 resulted in EMT responders on site and 4 transports to a medical facility for a higher level of care. So it works. So what do our clients say about this? There's one gentleman, this story just kind of astonishes me. He recently moved to Sanford, Florida, and no longer has Senior Resource Life Monitor. So just so you understand, this is a direct quote from him, so there might be some inconsistencies in syntax. For over a year, he felt safe while on this service. Every morning to night, I had taken a fall in the bathroom and laid on the floor for 2 days before anyone found him and had no one to call. After that, he was able to get this service and used it from when he got up to bedtime. And now he misses it up in Sanford and he's trying to have access to another one. Another client said, I felt very safe, especially as a cancer patient, to have an ADT alert device. I've been impressed with the checkups done periodically by ADT, so I'm sure it's working correctly. The fact that the device works in my apartment and when I leave is very important, so this is something that they take with them. I know because ADT walked my neighbor through the necessary procedures when he had a medical problem, that ADT does work in an emergency. So I'd like to ask Rosalind to talk a little bit about a new partnership that we're forming.
Hello, everyone. In an effort to continue meeting the need of what we're asking for, we are looking at all the avenues as far as partnerships and how we can collaborate with others to bring the need to the community and to the residents of Indian River County. And we had someone come in by Life Station and they did a presentation to our team. And we had a lot of questions, and especially since we're gearing now moving closer, because I feel that we've always been doing the health productivity and just the essence of just getting everything under the health language. So we had them come in, they did a presentation, and they said that they could do all the things that we needed as far as reporting, giving us access to data into their portal so that we can go in and look at all of the things that are being done in real time. If there's a button pressed and they get transported to the emergency room, we get access to find out what happened after that. A lot of times we don't get that information. So that will allow us to continue to report accurately and have that data that we need to continue looking at how we can continue to assist and give the need of the service to the clients that we serve. They will have multilingual, which we don't currently have now. We will also have ways that we can partner with it and also see if there are current clients that either pass away or that move and we don't know that in real time. They check those for us. They also are providing for us a way to see if those clients have other means that currently exist, like when their insurance, if it covers that, they look for ways to get those things covered through that so we can make a new space for a new client on the wait list. So they are really partnering with us to look at other ways and avenues to meet the need and to continue to serve as many clients in the River County as possible.
So any questions?
Yes, Bill Cooney, I'm surprised your number isn't higher. I have an Apple Watch, it goes off at least once a day.
Yeah, well, maybe we should switch to Apple. Seems to catch everything.
That's very good program.
Well, and it's Frank, I just have a question. So I've been trying to get my mother to wear, anyone who's elderly parents. I've been trying to get my mother to wear something like this, and I had the exact situation happen where she had fallen, she was alone for a day, she couldn't get herself up. Is there anything you guys do, and I'm not, is there anything you guys do to try to, do you ever get calls from kids with elderly parents who say, did you have a conversation with my, or to let them understand, my mother just don't accept the fact that she's getting older, that's what she's struggling with, but she needs it.
Yeah.
Because she falls. and she can't.
Coffee in the kitchen.
You guys do that as well? Do you get calls from?
Yeah, and we actually do have those conversations and we present it where it's really cool, especially the watch. They
Yeah.
seem to really
Yeah.
like the watch. 'Cause
It
they-
does look pretty cool.
It doesn't make them feel like you said, that they're aging.
Right, because we all remember those commercials from the eighties, you know, and that stigma's kind of.
Yeah, we haven't had a client that, a loved one that came to us and that we had the conversation and they actually tried it. They actually tried and liked it, so they stayed with it. So we do have those conversations and they're successful. Yeah.
And again, I may have missed, what's your level of private funding seeing Trudy here? Talking about that. You have that now, is that increasing, decreasing, do you need it? Or are we replacing that?
Are you talking
Private
about
funding,
the private funding?
yes.
So the only funding that we have for this program currently is the district and the state funding that we get, a little bit of state funding that we get.
Yeah, this program was originally by the district. The district actually came to us with this proposal a few years ago. And you had funded this.
Yes.
So it's mostly funded by the district. Like Robin said, we do have a little bit of state money because the continuing care for the elderly does offer a little bit of their funding for this program because they're in-home clients. So, but most of the funding, it has come from the hospital district.
But with that said, we are always looking for funders that
I
will.
thought you had some interim private funding.
We did have
Yeah.
some interim private funding when this program was on the sunset.
Yeah.
Correct.
Trudy is raising her hand back there because she did not want to let us go.
Yeah.
That's what I remember.
Yeah.
And I know the feeling, and I wouldn't wanna be on the floor for 2 weeks or 2 days or 1 hour. So I said to Karen, I'm gonna get this money, and we did with it, less than 2 weeks, but my friends don't wanna answer the phone any longer. You know,
Sure.
Something, you have to go after it, otherwise, no. And that's why I'm here today, because I'm hoping that I don't have to call my friends again, thank you.
So just as a reminder, the process that we went through last year in terms of that produced the reduction was a relook at the parameters of where we should be spending our money and how we should be spending our money as a result of pressures that exist in Tallahassee that may get greater with the tax reform that we're probably going to be seeing, some of the discussions around that. Additionally, the state Doge and some of the other things and our state reporting requirements and that exist to make sure that we can defend that the money that we're spending fits within the parameters of what's defined in the special act. So that was, I think speak for everybody. It wasn't just a desire to say no.
No,
And you're not saying that. That's mostly for those out that are watching. Specifically, what we made the decision to step down to give opportunity for each of the organizations that have been impacted by this direction to have a safety net. In other words, rather than just pulling the rug out from underneath you. Any specific entities, agencies that you guys have gone to for alternate funding? Or have you just gone to private sources, making phone calls?
We were in a position when we knew that this funding was going to be reduced, that we had to raise the money quickly. And to go through the process of applying for a grant or first identifying and then cultivating and applying for a grant, we would have had to turn clients away during that time. And that is why Trudy stepped up and was able to, generate that revenue for us. However, we're always, again, seeking out new funders. the issue that we have that every organization has, of course, I know we're not singular in this, but there are many programs that we need to provide funding for because the state money that we get and the federal money is limited. So for some programs, they may provide X amount of dollars for an encounter as you define it, but that doesn't cover the entire cost of that encounter. So we're always having to supplement the revenue that we get. So it's just finding the right funder to fit with each of these programs.
Just again, as we're going through this process and we're being watched,
Of course.
having information as to what potential specific funders, apart from the private calls, and I understand you had to triage.
Yeah.
This is not a critical question, it's
Of course.
it's hopefully an informative question for us as to what specific funders that you've gone to. It'd be helpful, and to save time on the next topic with regard to Meals on Wheels, the same inquiry will be helpful as we go
And
through the
that's,
process.
that's not just for Senior Resource Association. That's
Exactly.
For every
Everybody.
organization, so
Exactly.
don't feel singled
Yeah.
out by
No, just.
line.
Yeah, it's a question of the application.
Yeah, and I believe when we talk about Meals on Wheels, the gap between what the hospital district is funding and what we're receiving from other sources is much greater. I think it's 47%.
So why don't we make the transition?
Yes. So Meals on Wheels, I know you're all familiar with it, but just as a reminder, we have over 270 volunteers who deliver hot meals 5 days a week and provide 2 frozen meals for the weekend. Each of these meals meets 1/3 of a senior's daily nutritional requirements, and that's through our nutritionist that makes sure that that is the case. And we deliver more than 11,000 meals every month. Wellness checks are a critical part of this program, so it's more than just food, it's more than a meal, as we say. Our volunteers have eyes on seniors 5 days a week. They are trained by our staff to identify safety hazards, falls, other home hazards, health, what is their condition, is there illness, are they seeking more medication or different medication? And connection is so critical to mental health. It helps to reduce isolation and build trust. For many of these seniors, our volunteers are the only people that they interact with every day, even if it's just for 10 minutes, and what a difference that makes. In 2025, referring to these eyes on seniors and these wellness checks, there were 37 general incidents reported by volunteers. 12 of them were medical related, which represents 32% of incidents. So again, we have an app, it's called Mobile Meals, and there's a place for the volunteer to actually type in that there's an issue, or they can call them as well, call our case managers. All of this is relayed to the case managers in real time. And so if there is an emergency or there's an issue, we have immediate response. So our statistics, who have we been serving in Indian River County in 2025? We served 796 unique individuals through the following counties. You can see Central Vero is a major concentration of clients, but we're all over the county. So let's talk about the clients' ages. You can see that the majority of our clients are between 70 and 90 years old. We do actually have, I believe it's one client who's over 100. But again, the majority of people are in that age. And this survey that we took was with 213 respondents. So we asked for submitted surveys for everybody that receives the program, but 213 responded. So going to look at client income. So again, this too addresses goal number 2 for the district, for the uninsured and underinsured, to assist in the ALICE population. So you can see that 77% are living below the ALICE survival budget, which is really significant. So how does Meals on Wheels help clients? It helps them to continue to live at home, and these are direct responses from our clients and their caregivers. 92% say that it helps them to live at home. They eat healthier foods. They achieve or maintain a healthy weight. They generally feel better and it improves their overall health. So it is in fact more than a meal. So again, as we're looking at how this relates to the hospital district's goals, there was a article from Food is Medicine. It wasn't an article, it was a research paper. This really addresses goal number 3 for high impact preventive health initiatives to reduce hospitalizations for preventable conditions. Food is Medicine stated that diabetes, hypertension, and other chronic diseases are better managed with a nutritious diet. Of our clients, 73% require meals 7 days a week and 19% 5 days a week. So the majority are receiving food every single day. Food insecure seniors are more likely to have diabetes, congestive heart failure, and experience heart attack. So by providing these meals 5 to 7 days a week, it really makes a difference in managing their health issues. And coupled with all respondents having at least one chronic health condition, there are 61% who have 3 to 6 health conditions, and we're talking again about diabetes and hypertension, that sort of thing. 17% of our clients have 6 or more conditions. And as compared to those receiving health supportive meals, again, by providing these meals, we're helping to address these conditions that they have. So what do our clients say who receive Meals on Wheels? The program has helped in so many ways, especially with her blood sugar and diabetes, and she now eats more regularly. Seeing the volunteer has saved her from depression, and when she felt like giving up, Meals on Wheels saved her. They're exceptionally good people who always check to make sure he's okay every day. Truly appreciates the service. So we are addressing not only the physical health of these individuals, but also their mental health. And always talking about the wait list. There are 501 seniors currently on the public funding wait list, and we are feeding through philanthropy 248 of those while they wait. And on average, we have 30 seniors who call us every single month and are placed on that wait list. So as we're trying to pull people or feed people or move them from the wait list to state funding, we're always pulling people from the wait list to be able to feed them through philanthropy. So that there's constant motion as we continue to add individuals to that list. So it was wonderful to see Treasure Coast Community Health and whole family here today, because we've been talking with them about a collaboration that I think is really going to help us address in greater detail the health aspect of Meals on Wheels. And I'm going to turn it over to Roz to talk a little bit about that collaboration.
So after we did our survey, we saw all the results of how much more is needed. We put our brains together and we met first with whole family collaboration, and then we went with TCCH, and we did a mini survey with our clients to see what kind of Medicare they had, insurance they had, what kind of conditions did they have, how many did they have. Basic information that would get the ball rolling as far as what we need to see how we can make this collaboration work and meet another need of our clients. Because like we said, we can start here, but if we don't see them through, we leave them in the middle and then they don't get the care that they need and they fall through the cracks. So we recognize that this partnership is very important and it's crucial to the entire well-being of the client. So they graciously met with us and we are collaborating, and 98% of the home delivery recipients have Medicare or Medicaid. 91% have a primary care physician. 84% had an annual physical in the last year. -5 had a physical more than 1 year ago, and -11% couldn't remember when their last physical took place. The collaborative annual wellness visits will focus on prevention and early identification of health concerns, chronic care management, diabetes education and management, behavioral health screening and support, remote patient monitoring, clinical pharmacist services, prescription assistance, comprehensive dental services, substance use disorder treatment services, care management and health navigation telehealth are the things that will be offered to the clients when and if they're eligible to participate in these programs.
And what's great about these, working with both of these organizations is they offer something different. There's quite a few things that they overlap on, but we'll be able to identify which organization will be able to best serve them when we have that conversation with the clients. We put together a very, very draft marketing piece that I have enough here to share with everybody. But this is something that we will be sending to all of our clients, all of our Meals on Wheels and our emergency alert clients and our in-home services clients. So all of our clients will receive this. And it talks a little bit about what the services are that they can have access to. Actually, can I just take these? Again, keep in mind, this is very draft.
Yeah, don't hand it out to anybody.
Yes, please. There's no contact information, really. But this will go out to all of our clients, and then our case managers will follow up and see if there's any interest, and we'll ask them the question, do you have Medicare, do you have Medicaid, to try and figure out which organization would best serve them. And then we will work closely with both Treasure Coast Community Health and Whole Family to make sure that people are followed up with. We can get reports on, without names, of course, but we would be able to know how many people are being served. And it really provides more of a well-rounded, holistic approach, combining what we do and what medical services they need as well.
And can I just add one more thing? The 98% of the seniors that have the insurance, the assumption is that they're getting the healthcare that they need, but a lot of them aren't. And we're the ones that they trust day to day, that we communicate with them. So the warm handoff from us to the collaboration will be important, and that's the key, right? We want to make sure that they're being followed through and they're getting the care they need with the warm handoff and the trust that we've instilled with them to pass it on.
That's an excellent point, because one of the things we're trying to solve right now throughout the county is how many people need healthcare services or could see a doctor every year or have some existing condition they're not managing properly, but they're not, but they're not, how do we reach them? So this is an entry into that, tying it directly into the provision of healthcare services. The other thought I had when you were talking was, while everyone needs food, we need food to survive. Not everyone who has healthcare needs pursues those healthcare needs, but this is the tie into that. So interesting, yeah.
That's, if I may, related to that, I think in the last 6 months or more, the amount of marketing or awareness that you have now for Senior Research Association has been terrific. Radio, ads, everything is
Thank you.
optimal, really.
Thank you very much.
Any questions on Meals on Wheels?
I'll just make one comment. I noticed that the history, excuse me, the history of the district never funded Meals on Wheels until like 2023. Then in 2024, gave you $1 million. And you bumped up the number of meals served, a number of seniors served, day 42. But then last year, we cut it back 20-something%. I mean, I don't know the exact numbers, 700-something thousand. But you served, I think your slide said 796 seniors.
In 2025 in our
In
fiscal year.
2025, so you lost some of our funding, but you got some funding somewhere.
Yeah.
And my understanding was you raised a paddle at the Senior Resources Banquet and picked up the difference in one session, is that right?
Pretty close to it, yes, yes, our patrons heard the call. They heeded the call and they raised their paddle, and it was really quite amazing to be there and experience that.
It really doesn't have much shrinkage in senior serve, so congratulations.
This year.
And I'll just make a comment, To follow up on you and Frank, I really like the idea that you're gonna collaborate with Treasure Coast and Whole Family Health. That's terrific. That leverages the program. So good, thank you.
Thank you, thank you. And I'll just say, you know, one of our mantras is we never want to tell somebody that we're feeding that we can no longer feed them. So yes, we have people like Trudy, we have people who play golf with us every year, who also want to make sure that we don't have to turn people away. So we do whatever we can to make it happen. The key is keeping it sustainable.
Just an afterthought, I should have thought this earlier, but the presentation that you put up had a lot of helpful stats that I saw, a lot of people writing down. Why don't you send your presentation
I
to
actually have
Jenny?
copies.
Well, my thought is we can upload them to the supplemental information for everyone who did the LOI presentations today. So at least the data will be there.
Perfect. Perfect.
Just for
As they go. Right. I think they're there. Okay, thank you.
Thank you, ladies.
Thank you.
Thank you very much. Thanks. Appreciate it. Okay, Whole Family Health, Marie.
We actually, good morning.
Morning.
Thank you. We have just a brief one-page handout. So I don't have a PowerPoint presentation, but this is
All good.
Oh, good.
this one pager.
I just want to thank you.
Thank you.
Hey, Judy.
Bye, Trudy. Thank you for coming.
Thank you, sir.
And, you know, I did want to just mention before I get started into our program that we are really happy to collaborate with Senior Resource Association on their Meals on Wheels program because we provide services through the Treasure Coast Food Bank, a collaboration with them to many of our patients as well as seniors. And so I think it's a great idea to bridge that gap with the Meals on Wheels program as well as providing healthcare services. So speaking of bridging gaps, so our program that we're focusing on is called the Bridge Care Program, and it's a targeted initiative designed to close the gap between having insurance and actually being able to access care. And that gap is the underinsured patient population. So when we think about access to care, we often focus on the uninsured, but the underinsured is a growing challenge. These are individuals who technically have insurance, but in reality cannot afford to use it.
My daughter.
Okay, so we all know individuals in this group, they're facing high deductibles, large co-pays, and limited coverage for essential services. These individuals fall at or below 200% of the federal poverty level and are part of what is often referred to as the ALICE population, working individuals and families who are financially constrained despite being employed. As a result, they delay care, they skip lab work, and they don't fill prescriptions. And ultimately, they enter the system later, sicker, and at a much higher cost. So while they are insured on paper, they're functionally uninsured as the point of care, at the point of care. So our solution is the Bridge Care Program. And so what this is designed to do is it's a structured program that removes both the financial and logistical barriers to care for underinsured residents. And it does this in several key ways. First, it provides fee-for-service primary and behavioral health care visits, ensuring patients can access timely care. Second, it offers financial assistance to cover the deductibles, the co-pays, and non-covered services. Third, it integrates care navigation, helping patients move through the system, ensuring they complete diagnostics, follow-ups, and treatment. And importantly, this program is structured so that insurance is billed first, And then hospital district funding is the payer of last resort. So it essentially ensures that the resources are being used efficiently and only when the true gaps exist. So the targeted audience for Bridge Care, we're focusing on insured individuals with demonstrated financial barriers, patients qualifying under our sliding fee discount program, and households at or below 200% of the federal poverty level. We identify these individuals through financial screening at the point of care, data within our electronic health records, including patterns of delayed or avoided care. This allows us to proactively engage patients who are most at risk of falling through the cracks. So in terms of the data-driven part of the program specifically, over a 12-month period, we project to serve 513 unduplicated patients with 1,539 visits at a cost of $192 per encounter. And then also taking into account the average revenue from the insurance as well. But beyond volume, what matters most is the impact, and our primary performance measure is increasing the number of underinsured individuals receiving 1 to 3 primary or preventive visits, because individuals who are underinsured, when they can't afford their copays and deductibles, they're simply not going to seek care. So we're projecting at least a 6% increase in access over 5 years, and that may sound modest, but in population health, that level of improvement translates into earlier diagnosis, better chronic disease control, and significantly reduced downstream costs. Because you know that individuals that are not accessing care for preventative measures are ultimately going to end up in emergency care or hospital visits. So what makes this different and effective is that it combines the financial assistance with active care coordination. So we're not simply lowering the cost, we're ensuring patients actually complete their care. So through this model, the patient's out-of-pocket costs are reduced, patients receive hands-on navigation, and they also receive appointments, diagnostics, and medications, and we are coordinating that end to end. So essentially from a broader perspective, the program strengthens the entire healthcare system, reduces the avoidable emergency department utilization, improves chronic care disease management, prevents delayed diagnoses, and supports working individuals who do not qualify for traditional assistance. And importantly, it expands the definition of access. Because true access is not just having insurance, it's being able to use it when you need care. So as I mentioned before, our funding request is 513 unique patients with 1,539 visits. The program budget is $454,000, and our request of the hospital district is $295,488. So the services are reimbursed on a fee-for-service per encounter basis, and it ensures transparency, accountability, and direct alignment between funding and services delivered. So in closing, the Bridge Care is about closing one of the most critical gaps in our healthcare system, and it's about ensuring that individuals who are doing everything right, working and maintaining insurance, are not left without access to care. Ultimately, this is about making sure that coverage translates into care.
Dr. Mackey.
Yeah, Dr. Mackett speaking. Thank you, Maureen, for that presentation. Just a quick clarifying question, and correct me if I heard wrong. So with the $192 estimated per visit, I thought I heard that the patient's insurance was still going to be billed and that their cost share copay would be reduced. I didn't hear that it would be eliminated. So where did you come up with $192? Because in my mind, I'm thinking insurance is still gonna pay something. The
Yeah.
patient is still gonna pay something.
Mhm.
So where does that 192 come from?
So the 192 would come from the average revenue per visit for the underinsured patient population. So each currently patients fit into anywhere between 0 and 200% of the federal poverty level. So I would say about 60% are in that 0 to 100%. So essentially now they may pay a fee to us based on our discounts of say $20 if they're in that 0 to 100%. And then it increases from there to higher federal poverty levels. So overall of that entire patient population between 0 and 200% who have insurance, not who are uninsured, but who have insurance, we've estimated that we received about $100. And so the $192 fills that gap. So our intent is not to, we would bill insurance, but we're not actually billing the patient. And I want to make sure that's a correct statement, Colette, is that's correct, isn't it?
That's correct.
Yes, so maybe I miscommunicated that, but we do not intend to bill the patient. We intend to bill their insurance, and the difference would come from this program.
Good.
Carl?
Just along the same question as Dr. Mackett, I'm trying to process the math and how this fits into our fee for service model. Insurance company, healthcare facility bills at whatever their billing rate is. Insurance company gets it adjusted to usual and customary. That usual and customary is then used as a basis for payment and determining the patient's responsibility. How are you in that morass gonna have a fixed number that we're gonna get a bill for and know we're paying what we should pay as opposed to the difference between your billed rate and the covered rate irrespective of usual and customary?
Right, so because we're doing it as a fee for service, which is what I understand the hospital district model is. So we're looking at the average cost of all of the underinsured patient population. So
Are we gonna get a flat rate then per
Yeah.
patient
Yeah.
as opposed to?
192 flat.
the
rate.
192 is the flat rate. So if we look at, and our CFO is available to Dan to kind of go through those numbers. But if you look at the 192 versus I would say 103 adds up to the 295 for the uninsured fee for service visit that is being billed to hospital district now. So I believe that's essentially the same number. Is that correct, Dan?
Yeah, what Marie's trying to do, let me just jump in for a second. I think by setting a rate, she's trying to simplify a very complicated matter because all her commercial contracts are gonna be different.
That's
it's
the
very
point of my
compli-
question.
We
It's a
can
very
talk through what that
Well,
rate.
let me follow. So that average that you came up with has places that you've collected the data in order to do the calculation.
Absolutely.
Is that differential based upon your build rate or usual and customary?
It would be what we've collected.
No, that's the bottom part. Okay, so you've got the amount that you would hope to get, the build rate or usual.
Oh, yeah, there is obviously,
That margin, I would like to know your formula for that, determining the margin that gives you the 192 per visit. Because there's a big difference between usual and customary and your build rate and so forth in certain areas. And I want to make sure that I understand I want to precisely understand how the 192 average was arrived at.
okay, well, let me ask our CFO.
But you understand the difference that I'm asking between your build rate, usual and customary, and
Of course, yeah, so our build rate would be 180% of the Medicare allowable. Our build rate needs to be the market rate.
Right.
That's what's required of us, is to start with the market rate. And then it's discounted from there, and then, of course, with our various insurance plans, we're receiving different types of reimbursement. So rather than estimating, or, you know, I can let Dan explain, you know, how.
This is probably something that needs to be.
Right, I'm
added to
asking the question so that you
Right,
can, right, so that
right.
later in this
Right.
process,
Right.
you can inform us on the question. And we have
Right.
calculations and a basis for it, we know, in other words, so. It's
Yeah, we can.
as
provide
part of
that
the
supplement.
proposal,
Yeah.
thank you.
Michael,
It's interesting that the three trustees on this side of the table all went in the same direction in terms of their
this
questions.
is special.
I guess.
Exactly.
You're all sitting next to
Yeah. The reality, what's gone through my mind is we have oft said we want to focus on that uninsured and underinsured population. And with one or two exceptions, I can't remember where we've really stepped out and found a way that we could do it.
So this is interesting.
And so it is an in the weeds question
Mhm.
that I think we, you know, if we really want to be focused on this population, I think we should be. We've said that. We need to figure that out.
Yeah.
So this is a good exercise that's kind of forcing our
We're
hand.
happy to crunch
It's
numbers.
forcing our hand as
Yeah.
well. Yeah.
It's a way to get more folks access, though. We just have to figure out,
Yeah.
and just talk through this a little bit more. But I will say, Paul, to your point, one of the things that, Jenny, I don't know where it's in the application, maybe question 4 or 5. We specifically asked in the application for everyone, if you provide clinical service by a licensed medical provider and to deliver clinical services, you know, do you bill? So that's a standard question now, and we're ensuring that everyone who can bill does
That's
bill.
Bill.
But we still have to work out some details.
Yeah.
Any other questions? Great.
Thank you.
Thank you very much.
Thank you.
Madam Chair, I just want to
Yeah.
comment on how helpful this type of session has been. And I appreciate the staff organizing it like this. I wish we could hear from every program.
Very helpful.
We got a couple weeks.
Yeah, it's worth it. I'll tell you, it makes the decision making a lot easier.
Well, and this was done for obviously new programs, as we all stated. And there might be a need to do something for our.
Reoccurring,
Our recurring,
I agree.
so
Mhm.
that was gonna be my question, did the trustees find this helpful?
Absolutely.
This format where we stayed really tight to what we were doing,
Mhm.
and so thank you for that feedback. Paul, you look like you're gonna say something, okay.
Yeah.
Not yet, okay. So that concludes that, other business.
Madam Chair, I'd like to address the motion made and passed at the March chairman's meeting. Specifically, there were 2, but this is really addressed to the first motion made concerning the separation of TCCH's CEO and the request for bylaws, board minutes, and executive session minutes concerning the CEO separation. I was on Zoom for that meeting and was listening and following along. And have also reviewed those meeting minutes due to the nature of the motion. I wanted to ensure as district council that we are requesting things that we have statutory and legal authority to request so that we don't expose the district to liability, and also that we don't do anything that could be harmful to the healthcare that's being provided in our community to the population that we seek to serve, or to any of our funded agencies. And so also, before we begin, I want to tell everyone I've advised Dr. Mackett, he doesn't need to recuse himself or leave the room for this discussion. He is a part-time per diem physician with TCCH, but this discussion is really focused on the higher level authority that the district has. If the conversation were to go in a direction where he feels that he has a conflict, due to his employment, he would recuse himself. And if there were a vote taken today, I have recommended that he abstain from voting, due to his employment, but he's not got to recuse himself, at least at this point, for this part of the discussion. And I also wanted to share that
because it was Paul's motion, I did reach out directly to Paul along with Dana McNally, who works for me, and Frank on Friday, so we did have a discussion about this as well. And then we did circulate a legal memorandum to all of the trustees yesterday, and certainly that's a public record, so if anyone wants to request it to review it in detail, it's available. But again, I really wanted to double back on this because of the nature of the request and the reason of the request. And so, again, my read of the minutes, so what we're focused on as counsel for the district is what we're able to do. So we're a funding agency for the entity at issue and all of our other funded agencies. And so we have the ability to request certain things as a funder. We also can request certain things under Florida statutes, case law, our governing legislation, the special act, through our audit process. And so certainly we can request a lot of things if we felt that there was a misappropriation of funds. But if we are simply requesting things to determine if an agency that we fund complied with their own governing documents or their personnel policies, our position that's been outlaid in our memo is that that is an overreach. And the recommendation would be that the motion either be rescinded or amended. And I do want to explain to the board that anyone can make that motion to rescind or amend. It would require a second, of course, for discussion. And it would also require a 2/3 vote because there isn't any sort of prior notice of this motion other than the memorandum we all received, which I don't really consider to be a prior notice. So Dr. Mackett is abstaining from any sort of a vote. If there is a vote taken, 2/3 of 6 is 4. Okay,
Would you recommend that a motion be made and then move to discussion? I know Paul would like to share his thoughts, so how should we do that to be
Well,
appropriate?
well,
that is my recommendation.
my difficulty with that proposition is, council has been given an opportunity to express a point of view in writing and just now. And I would like to have the same courtesy before the motion is made,
Okay.
because it may actually affect whether a motion gets made and what that motion might be.
Go ahead.
Sure. I found it interesting that the memorandum we just received expresses a narrow or strict construction of the special act. In August 14th, we received a memo that said just the opposite, that the special act should be liberally construed. What I'd like to do is start at the end in terms of what the process is. We kind of talked about it at the meeting the other day or last month. I didn't make a suggestion because I didn't want to make anything and have it be complicated. First, I agree. We have no interest. I think everybody, I can go through to the minute when we collectively agreed that this was not about delving into HR matters and telling them who and why they can't hire and fire anybody. It was a process conversation. And I think that needs to be clearly reflected in the minutes. I think that could be punched up a little bit from what I've read. But that needs to be made very clear that nobody here, I wasn't advancing that cause, everything to the contrary. The next thing was an inquiry, and I think Alan brought this. Well, what do we do if there is a problem? Because we're not going to do that. We're not going to punish them. We don't have the authority or the inclination to do that. I don't. Okay. I don't know what we would do. We're on a fee for service basis. So there's nothing that we're going to do there financially. We're not going to rescind the $1 million grant. What is our responsibility as I read what I'm going to be going to is making sure that we solve problems and we raise the bar. What does that look like? If there is a difficulty, the difficulty lies, and I didn't raise this topic because I didn't want to seem inflammatory or dramatic, but the real issue has to do with their FQHC status and the requirements that go along with that. As I understand it, the federal code of regulation tells them how certain things they've got to operate. They've got to have a board with bylaws and the composition of the board and how they relate to their CEO. Okay, that then is translated into another group of documents that are put together by the Health Resources and Services Administration. They have a guidebook, and that administration is charged with the responsibility of oversight of the FQHCs and their following of that document and the requirements of that. My concern is whether or not those elements were properly considered in the process. That's really the weakness. How do we address that? We go to TCCH and say, we would like you to implement a training program so that your board members and your executive leadership have a firm understanding of those procedures and requirements as a remedial measure, plain and simple. In other words, if we found a violation, that was going to be the next step. I didn't go there because, again, I didn't want to complicate the topic. As to our engagement, the Special Act has language in it, liberal construction. We have the authority and the right to enter into contracts. The Board of Trustees shall determine the terms of such contracts. Our contracts funding agreement, subpart 8, agency agrees to make all records available to review at the request of the district. All records. All records. It's part of the agreement. It's paragraph 9. In performing its obligations hereunder, each party agrees to comply in all material respects with all applicable laws. Okay. That's what pulls in the FQHC requirements, because the federal code requires certain things from them, and I can go into them. You know, their board membership, 51% has to be patient-based. Any decision that is made, the guidebook says hire, fire, review. Hire, fire, review of their executive leadership has to be made by the board. That would be the board composed of 51% of patients. I'd like to know, did their whole board participate in this decision, or was it an executive committee? The rule specifically says that can't be delegated. I can read it to you if you'd like. Okay, so that's federal rule, federal law, federal regulation. Did they comply with it? Yes or no? I think our contract and our statute and our policies take us there, because our policies include a governance audit, not just a financial audit. When an organization signs an agreement with another organization that has, like ours, we have stated rules and regulations. They're assumed, because those are public record, to have knowledge of their content, their implications, and their requirements. So this is all part and parcel of the same deal, okay? And whether or not they read the rules, whether or not they were familiar with the FQHC requirements, simple question, whether or not they followed them. If not, the remedy for us, and I think for the future, with regard to our contracts, we probably need to punch up our contracts so that we contemplate some of these things, so that we do have the ability to do what we need to do. And possibly requiring some degree of consideration by the organizations, depending on where they're positioned. And there may be some boilerplate language we can use to get there, of compliance with whatever appropriate or relevant governing authorities that they have to comply with. So that's why I'm not rescinding the motion. I think the motion is appropriate. I think that our contract with them gives us the ability to get those documents. And it has a structure between the special act, our rules, the agreement, the rules governing AFQHC collectively give us the authority and the obligation to do what we did.
Dr. Mackett.
Yeah, Dr. Mackett speaking, and I'm going to be very careful
because of my potential conflicts. So I'm gonna frame this as if this involved whole family, which is an FQHC lookalike organization, which is still governed by federal rules and regulations and governed by HRSA. That was referenced by the city of West County. You know, so my view, especially in light of the recommendation from council, is that while we do hold under the special act a lot of the powers enumerated by trustee Westcott with regards to our funding of an organization, I truly believe that we are not an investigatory organization or an organization with adjudication authority. So if this were to apply to whole family, if we had a question about them, I would think that any complaints in the regard of personnel, bylaws, questions, etc., if they did not fall into our funding authority and our funding agreement or contract, that if anyone has questions about those should be brought to HRSA or to the federal government, who does have investigatory and adjudication authority. That's my view.
Well, I hear you, and I'm not looking to have us necessarily adjudicate, but remediate. And we need to change our rules. We need to change our contract. So that there is no, in other words, if we're not going to do it, you know, if we then their governance procedures, looking at their which we've done with other organizations. You know, this isn't, you know, there've been lesser organizations, by lesser I mean smaller, with less political muscle, that we've done this with. And you know, let's not do it then, period. Let's change our policies, and that's gonna be where we are. But I think that's a mistake, and it's a mistake because I think we're at ground level. We can avoid potentially, on behalf of the organization, an acceleration of a problem. And I think that's why we have the governance rules, is so that we can go in and triage and come alongside. And that's the intent.
Michael?
I seconded Paul's motion last chairman's meeting. He's elaborated from a lawyer's point of view and has gotten into the weeds for what was in his head, because we couldn't know that. From my perspective, I saw this as an opportunity to begin a communication, which is part of the document that we got from your office. Communication can only be a positive thing in all aspects. And there may have been some communication between TCCH and Frank, but there really hadn't been any with us. I also didn't think, because I've lived another life, again, different in the nonprofit world. And it was philanthropic funds that we were dealing with at United Way, not the public ad valorem taxes here. I've lived through a couple of really interesting situations with not TCCH, but other nonprofits, where that agency very much got into the weeds in reviewing a lot of the documentation so that we knew things had been handled from our perspective correctly. I think those were the two factors from my point of view. One, and I think I was the one, if I wasn't, I agreed with it. And again, that asked they should come and talk to us. I think it's important that we know Miranda, she's been around a bit. They've got a brand new chair. I haven't a clue. I think that's an important discussion or an opportunity that we'd have if there was a discussion. But again, at a core level, maybe it was an awkward way to get there, but I saw it as opening the door or starting communication and letting them know we had some concerns just because of all that has transpired in a short period of time. Not just the transition of leadership, but the impact it had on several other agencies that are funded by us.
This is not substantive, just for clarification of the record. I'm referring to chapter 19 of the Health Center Program Compliance Manual, chapter 20 of the same document, and title 42 of the FCR 51C 304. I've given these to Frank already, and if you all may be interested in looking over them so that you can see, it says what I say.
Yeah.
For yourself. There's also a good National Review Law Review article that kind of goes over some of this too. That if you Google it, it's the only thing really that comes up.
Comments from other trustees, Dr. Cooney?
This is Bill Cooney, commenting, I think in principle, I agree with Dr. Mackett. I think that, at least to my knowledge, we are fiscally involved with all of these organizations and agencies. But I was not aware, unless there's information I don't know about, that we're involved in their governance. And I refer back to my time, of course, at the Mayo Clinic, where we have the board of trustees, the board of governors, and if there were errors in perception of one man's work, for example, a friend of mine in laboratory medicine lived across the street. He got engaged with another company inappropriately, and the next day the door was locked, computers were gone, everything was out. There was never a question of whether or not somebody should or should not be doing this. This is how governance works in a major organization, and I think here that we're overstepping ourselves, and I actually would propose a motion that the Mr. Westcott's TC review bylaws and meeting minutes, including executive sessions, be rescinded, and that we look forward to working with that organization in a financial matter, but I have to support Ms. Pesky's documentation, very elegantly put together, particularly on paragraph 2, page 2, paragraph 1, where Florida Uniform District Accountability Act clearly states that this is not where, in my view, that our hospital district belongs. I mean, there's other documentation in that as well, but I think that kind of summarizes at least my view on it.
Was that a formal motion?
That's a formal motion.
Do I have a second for the motion?
I second.
Further discussion?
I just comment that I'm uncomfortable with this discussion. When Paul brought this up last time, I sort of quietly abstained. I did not vote. Nobody noticed. I should have spoken up. But then Paul and I talked about it in the public meeting, or after he commented, he noticed. My feeling is, I'm not as concerned about how TCCH is governed. I'm concerned that the CEO and the CFO have been changed. And I want to be sure that's not representative of some other issue, particularly financial elements and the way they operate as an organization. Whether they did things procedurally exactly the way they're supposed to doesn't trouble me as much. I don't think it's my business. If they're not serving the public and doing so in a fiscally responsible way, I care a lot about that. How they make these decisions, things happen where you got to deal with. I think it was Keynes had said years ago, when the facts change, I change. And I feel like something happened in TCCH. I don't know why. It's not up to me. If it affects how they serve the public and how they operate financially, then I care. Beyond that, I trust the board of TCCH until I get some evidence to the contrary. So I think I fall in the same category as trustee Cooney and Dr. Mackey.
Karen?
I second the motion because I do trust our council. Our council's advice, I agree, Alan, 100% with what you said. I think that there was another motion made, and it had to do with financial. And I think that still stands, so there is information that we have requested that we will get that is in our purview. I agree with Dr. Mackett's philosophy, Dr. Cooney's motion, and what Alan has stated as well.
Do you have anything else that you?
No, I would support actually what Alan said, but when we first proposed this, I was uncomfortable. I just didn't want to think that we're in bringing leadership of a well-known organization in our community in before us. And in a sense, having an inquisition of their leadership, that's not very comfortable from my standpoint of a role we would play. If there's something about governance I don't understand, then that's different, but financially, I think we have a role, we have a responsibility. But if we start this now and set a principle, where does this go with the other 25, 26 agencies? Are we gonna be overlooking their shoulders, so to speak, on everything they do? I don't want to be part of that. I don't want to put the time in to do that.
There's a wide gap between an inquisition and communication.
That's fair.
At the heart of it, if I'm being forthright, and I should be, the separation of the mental health court and We Care. Some of the actions taken subsequent to or along with the transitions just made me worry and wonder about, are they in over their head financially? And at its core, that may have been where I was coming from. Didn't know there was going to be a second motion, kind of thought that maybe the first motion was in fact going to be able to answer those questions, but subsequent discussion led to the other. At the heart of it, I've never suggested, and I don't want to believe that there's been any malfeasance on the part of anyone at TCCH, prior staff or current, but questions need to be asked, or I don't think we're doing our job. I think that communication can be had. They have to be forthright as well. I think they will be. It's not easy doing this job. I lived through a couple of moments at United Way with similar situations, and they were the worst time that I spent in that organization in 25 years, but you got to go through it. And we did it right then. I think we're doing it right now. We'll satisfy the concerns that any of us have, see where they're at. I'm not anticipating that there are issues, but we need to know for sure what's going on.
Maybe I should restate that word, just a little harsh. Harsh. But I guess my point would be, agreeing with you, Michael, is there ought to be a process where we can do that, that's not coming before our board and putting it publicly.
Right.
I think that's not acceptable. That we have a public session, review of this, and it ends up in the press and other places. That's not how we.
I hate that too, but we don't have the option to do anything outside of publicly.
Just for clarification, I appreciate you rescinding the inquisition mark, because it's not intended, in the weeds has been used as a phrase. This was a very simple question. Did you or did you not have your entire board involved in the decision? Plain and simple. That's the question. The importance of the question is the protection of the asset that's valuable to this community. And that asset is their FQHC status. Are they gonna, let's, for the sake of argument, assume that they didn't have their board and somehow that is I'm not an expert in this. Unfortunately, I know more about it than I ever wanted to. But if it is a violation, from what I understand, the scrutiny isn't likely harsh. I don't know. In other words, it's a graduated process, I think the federal government takes. But if there's a problem that needs to get headed off, I think it's our responsibility to do so. So that was the spirit of the effort. And still is.
Can I make a quick comment, just because I'm familiar, because I do conduct the audit? After the last meeting, I did review their 2024 financial statements. We don't have 2025 just yet. They should be coming to us at some point before June. But there was no designation that TCCH was a going concern in their last audited, and that is a single state audit. So that's not just a regular financial audit. It's more in depth because they received federal funds. So they didn't have any deficiencies. They didn't have any material misstatements. They were actually designated as a low risk auditee on the federal side. They still go through the single state audit, but there was no going concern. So if a CPA firm conducts an audit and they think an agency has cash flow problems, they will label them as a going concern. We saw that with one of our agencies a couple of years ago. So at least at that point in time, there was no going concern designation, which I think is important to note. Another thing, because they do look at their HR policies, they do have a CHRO on site, a certified human resource officer. I don't get involved with their personnel matters. I review the handbook. Yes, they have it. They have, the proper things in place. I know they do have a very comprehensive handbook. But they do have a certified human resource officer employed by the organization. And I just think that's a really important point to bring up to the trustees, so, everybody is aware of that.
Just in response, again. The question I raised is a governance question, not a financial one, so it wouldn't show up in a financial audit. Additionally, the issues didn't come to the surface and percolate to where they are till the end of last year.
Right.
So it's not covered in anything that's been looked at yet.
Right.
So I'm not sure that helps us discern anything. But
there's still the second motion. That was
correct.
lost.
Yes, that is not.
Which will
Starts
answer that
exactly.
question, which will
Right.
answer that question.
Right.
Just a general question, Paul, because I haven't researched it the way you do, and I respect what you're trying to do in a way. Is there some communication or method where the higher federal agencies can come into play and give some? Seems to me they'd be the logical people to.
But I think we want to avoid that, from the government. I'm here to help you is not really anything all about here. And that's part of the process as well, is avoidance of that. And maybe that's the answer. Maybe, we step out and I'm not, I mean, I know they have a self-reporting in the federal FCR, there is a self-reporting requirement. And my guess is your failure to self-report is in and of itself a violation. So if there are issues out there, by not going to the federal government themselves, maybe amplifying whatever difficulties may exist if there is a problem. So.
Jennifer,
Yes.
are we to the point where we are feeling like we can vote?
I am.
Public
That was gonna be my question, is to ask for public comment. I
As
asked
the
for it now.
discussion is closed, you should call the public.
Okay, is discussion closed?
Any other
Well,
discussion?
I just want to make one quick comment. I in no way meant to discourage Paul in this, and what he's trying to do. I think he raises an interesting question, but we're having to raise it in public. And I would rather. I just don't think that's our role. So I'm sorry.
Thank you, Michael.
It's an ancillary, but, I'm sure that the leadership at TCCH was invited to speak, or were they not formally?
No, they were not formally
Okay.
invited to speak. There's no agenda item.
I knew there was. I didn't know if that's that's what I was getting at, because I still they might like. I would like to have them come and we'll have
I'm
conversation.
sure they'd be happy to.
Yeah.
Okay, I'll open up for public comment. Yes,
Hi, ladies and gentlemen, my name is Theda
so if you
Howard.
come to the table so that we can make sure that you're heard, thank you.
Needs to state her name and her address.
Okay.
Sorry, I'm a little slow.
No,
That's all right. Ain't we all?
welcome.
Thank you. My name is Theda Holland,
Could you state your address too as well? I'm sorry.
1166 15th Avenue Southwest, 32962.
Thank you.
I am a member of TCCH board. Have been for approximately 7 years. There's only one other member that's been there longer than I have. And I want it known that I am very concerned about what happened. The board was not consulted. It was never brought to us. Very nervous.
Okay, we're friends.
The board did not formally find out what happened until 2 months later. And I am concerned of, most of you, the financial consequences of this with FQHC, all of it. And I just haven't known where to voice my opinion, but I think there's real cause for concern. And I welcome any questions.
Thank you very much.
I don't know
Thank you.
what question to ask you.
It's public comment, so yeah, here the comment. Yeah.
Oh, okay.
My comment.
Thank you.
Thank
Thank you for
Thank you
your.
for speaking up.
Thank you for your patience.
Is there any other public comment? Are you seeing anything
Sorry.
online?
No, nobody's raised their hand.
Okay. So we have the motion on table. Could we please read back the motion just to make sure we're all on the same page?
Okay, he proposed to rescind Mr. Westcott's motion, so I would go back to that original motion in the minutes and write that up, so. Basically, there was quite a few documents that Mr. Westcott had requested, that wasn't stated
Yeah.
in the motion.
Jennifer, would
The
you?
first motion made by trustee Westcott at the March chairman's meeting sought to request TCH's bylaws and board minutes for the past 6 months, including executive session minutes concerning the separation of TCCH's chief executive office. That is the motion that is,
But
we've been discussing,
Right.
and our recommendation was to have it either rescinded or amended.
And he made the motion to
Dr.
rescind
Cooney
it.
made the motion to
Yes.
rescind.
okay. I'm gonna ask for each one of us, I thought I saw.
Just for clarification. I want to make sure we're clear. It's not redacted, it's just rescinded, so it's going to be reflected as a change in these minutes. That action is going to stand as it reads.
Correct.
Okay.
Yes. All right, those are the minutes of that meeting. So let's, Dr. Cooney, your vote, please.
Positive to rescind them.
Aye.
Yeah.
Okay,
Aye.
aye. Michael?
No.
No.
Under advice of counsel, I
Yeah.
think.
Thank you. So,
So I heard four ayes,
Yeah.
so motion carries with 2/3, vote to rescind the March chairman's meeting, motion made by trustee Westcott.
thank you. Is there any other business with the other motion? That second motion stands and we are.
Correct, and
asking
under our
for-
recommendation, the motion, the second motion made by trustee Deagle requested recent financial audits, January and February financial statements, key performance indicators and information related to the departure of TCH's latest chief financial officer, so the CFO, not the
Mhm.
CEO.
Yes.
And that, we found that motion to be appropriate within our statutes and our governing, enabling act and case law, so that motion is not up for, we are not recommending that be rescinded or amended today and that it stands.
Okay. And we have moved forward with that or?
Correct, so what we're doing in that case is, I'm gonna collect the documents. Dawn and I are gonna sit down and review them, she's gonna produce a report, as she does with the audits, and she's gonna communicate that with the trustees.
And we are going to be asking them to come and speak to us.
I'm not gonna speak for them, but yes,
Put the invitation out.
Yes.
yeah, the invitation was out.
Thank you.
I already communicated
Okay,
that to them.
thank you.
Yeah.
This would be at like a May chairman's meeting. When would you like that to happen?
Sure.
Just so I can reflect
Yeah.
that. Okay.
Midterm team.
Invitation was out for the financials.
Yes.
But part
I
of,
thought you already told, or you said they were not formally invited.
no, they were, that was in my email. And I believe, I don't know if I forwarded the email to you guys, but yeah, they were. I specifically invited them in the email I sent after that meeting that day. So correct, they were invited, but they were not on the agenda for today, correct? They weren't invited today. If you remember what the motion was, it was, once they collect the information and we go through it, they would
Then they
attend a
would come.
subsequent meeting.
Yes.
That was the motion.
Yes.
So, and this is Frank, I just want to suggest something else that I think might be helpful, and we talked about it a little bit, I talked about this a little bit with Paul and our council was involved. Is we do our funding agreements with every organization every year. And in the 3 years I've been here, every year as we learn new things, we tighten them up. So as long as, we welcome trustee suggestions on the agreements, as long as they comply with the direction from our council and we're in the confines of what we can do as a special district. Any input you have to make the funding agreements, more effective as you see it. We're happy to take those recommendations.
Absolutely. Okay. Any other business? Piece of business, for myself, at the May 20th chairman's meeting, I've got a slight, conflict at the end. I'm wondering, would you all be willing to do 8:30 to 11:30 AM on the 20th?
If you'll open that bridge, I'll.
I am.
It's your rowboat.
We all-
Be fast enough.
Okay, thank you very much for that.
Remind us.
Yeah.
I'll send out,
Lots of times.
I'll send out a calendar adjustment.
I'll call for other public comment. Hey, do you see any?
I do not.
Okay. You stand adjourned.
Thank you.
Thank you.
Yeah.
See y'all tomorrow.